Hello everyone, welcome back to the question paper discussion of pediatric dentistry. We are into the part 3 of the mini sessions. So in this session, we'll be looking into the behavior management techniques in Pedodontics. It's a very vast chapter and many questions will be asked from this chapter. So the first question we have is the classified behavior of children. Describe behavior management techniques employed in dental office. And the tail end is add a brief note on tell show do. So this last part can be any question. It can be desensitization, it can be home, it can be aversive conditioning. So it can be any question, but this is a common structure of behavior management question, that is a definition or classification, then describe all the techniques. It could be psychological, physical and pharmacological, and then write a brief note on any one of those techniques. So we'll start with the classification of behavior that is given by Lampshire in 1970. The first one is cooperative, where the child is physically and emotionally very relaxed and is very cooperative throughout the procedure. Whereas the second one is tense cooperative. The child is tensed at the same time is cooperative. Then outwardly apprehensive. Actually, these type of kids avoids treatment initially. Usually hides behind the mother, avoid looking or talking to the dentist, but eventually they accept the treatment. Then we have fearful. They requires considerable support so as to overcome the fears of dental treatment. Then the stubborn people, they passively resist treatment by using techniques that have been successful in other situations. Hypermotive is a child who is acutely agitated, they do screaming, kicking, all those tricks to avoid the treatment. And we may have handicapped, physically, mentally and emotionally challenged people and emotionally immature kids. Next classification was given by Bingham. Category 1, emotionally compromised child. Category 2, shy and introvert. Category 3, frightened. Category 4, child who is adverse to authority. And we have Frankel classification. The Frankel is given as definitely negative, negative, positive and definitely positive. In definitely negative, as the name suggests, they refuse treatment, cries forcefully and they are very negative, uncontrollable and defiant behavior. Whereas negative is they are reluctant to accept treatment and they displays evidence of slight negativism. And positive means they accept treatment. Definitely positive is unique behavior, they are pleasant, they accept treatment without much problems. Then we have another classification, that is Wright's classification. They are cooperative, lacking cooperative, potentially cooperative. Under that we have uncontrolled, defiant, timid, tense, weaning behavior and stoic. Now let's see what are the types of fears in dental situation for children. So fear we can classify as general fear, or also we have dental fear. So fear is nothing but an unpleasant emotional state consisting of psychological and psychophysiological response to a real external threat or danger. It can be alertness, tension and mobilization of the alarmed reaction. Or it can be also defined as a painful feeling of impending danger, evil or trouble. Or in simple words, we can define fear as a reaction to a non-danger, whereas anxiety is to an unknown danger. There is a difference between fear and anxiety. So this question is about type of fear in dental situation for children. So dental fear, it can be fear of pain or its anticipation, fear of betrayal, fear of loss of control, fear of the unknown, fear of intrusion. So fear of pain or anticipation, it is like actual or misinterpreted pain or the anticipation of the pain. Unfortunately, discomfort and sometimes pain can still be a feature of dental treatment today, no matter how careful we are about trying to ensure about adequate analgesia. So the research evidence suggests that uh, the trust of the dentist is a very important factor in dental fear. And fear of unknown or fear of is like in anyone's eyes, a visit to a dentist may be classified as a potentially threatening situation. And fear of intrusion is like most, if not all, the dental procedures are invasive. So intrusion involves impinging on patient's personal space into a bodily cavity, the mouth. Impinging on a patient's personal space, something that is taken for granted by professionals. So they perceive this as a part of their caring role, even if the patients dislike the procedure intensely. So some children find this invasion of personal space very threatening. So that is fear of intrusion. And a fear of loss of control. The children are used to being cared for or controlled by parents. So they have an innate sense though of the boundary that defines the social from personal control. So letting a 4-year-old child choose which tooth to polish first gives them an appropriate degree of control. So that loss of control is a problem for the kids, because a 10-year-old may request that easy treatment is completed at a particular appointment because they have examinations afterwards or they are not feeling well, thus offering control over the noxious stimulus. They have the control. So ultimately, or the overtly offering children the opportunity to ask questions enhances their control over the information gained, thus offering decisional control. So this fear of loss of control is a problem for the child. Now we have the same question. What are the methods to reduce dental fear and anxiety in children? And a note on the first dental visit of child. So I have already explained the definition of fear. So different types of fear corresponding to age. We have many types of fear in different age groups: 0 to 2, 2 to 4, 4 to 7, 8 to 10, 11 to 13. Like in 0 to 2, strangers, loud noises, strange objects. 2 to 4, being alone, darkness, animals. So it goes on like that with respect to various age groups. And various behavior management strategies. We can do primary, secondary, tertiary, and pharmacological management. On primary, we have safe, controlled environment, sense of control to the child, pre-appointment approaches. In secondary, that is behavior treatment, communications, behavior modification, parent in the operatory field, distractions. Tertiary level, we have desensitization, modeling, tell-show-do technique. And pharmacological, we have many techniques: nitrous oxide, oral sedation, rectal sedation, parenteral, aversive technique, and GA. So what are the common procedures carried out during the first visit? That is a history taking, social, dental, and medical history. Then the extraoral, intraoral, and after that radiographs, and explain aims of the treatment to the parents. And we do only simple procedures at the first visit, that is if there is emergency at present, and treat for pain. And we'll do prophylaxis just exclusively on the incisors and maybe topical fluorides. So now we have so I was talking about the first visit procedures for a fearful child. Now we have dental fear and anxiety. So anxiety, as I explained before, it is a state of apprehension to a unknown danger, whereas the dental fear is all those emotional state is or a reaction to a non-danger. Okay, that is the difference, fear and anxiety. Now we are into the most important section of this chapter, that is the classification of behavior management techniques. You will get definitely one question. It could be a long essay, short essay, or short note from this section in Periodontics. So we have basically three categories in behavior management technique, that is psychological, physical, and pharmacological. Psychological, we have pre-appointment behavior modification, communication, use of second language, tertiary technique, dental love care, desensitization, contingency management, visual imagery, modeling, behavior shaping, assimilation, and copying hypnosis. In physical approach, we have home physical restraints. Pharmacological, we have pre-medication, conscious sedation, and general anesthesia. So in psychological approach, the first thing is pre-appointment behavior modification, that is the contact with child's parent before the first dental visit. It increases likelihood of a successful dental treatment. So that is very important, pre-appointment behavior modification. Second one is a communication by involving a child in a conversation, which relaxes the youngster, and we can have two ways of communication, that is verbal and non-verbal. So basically it enhances the effectiveness of other communicative management techniques, that is a non-verbal one, and it gains patient attention and compliance and motivates the patient. So the verbal communication, it should be at the level of child, that is effective vocabulary should be used. Communication with children aged 2 to 7 years should be based on the animism, like giving life to an inanimate object, which involves giving life, like names to dental instruments, like hand pieces is like a whistling Charlie. And the important aspect of communication is getting the child to respond to dentist's commands. Two things must be remembered, that is the command may take some time to sink in and be implied with, and the second thing is the command should be within the ability of child. Okay, so it should be within the ability of child and it takes some time. So that was about communication. And we have audio visual modeling, that is using video cassettes. Types of model can be used, can be siblings, parents. It is best recommended in same age patients. It can be a descriptive praise, that is a praise emphasizing on specific cooperative behavior, and it can be signaling. So signaling allows the patient to communicate with the dental team during any phase of treatment by means of previously established signal with specific meanings. The patient, by raising a hand or a finger, can communicate their wish to stop the treatment, for rest breaks, or to notify dentist of an unpleasant feeling. They can give signals. Whereas a descriptive praise, like the praise emphasize specific operative behavior, like thank you for sitting still, or like you are doing a great job keeping your hands in your lap, rather than a generalized praise like good job. We need to be very descriptive because we are dealing with child, so we need to be very elaborate, like you are doing a great job keeping your hands in your lap, rather than saying just good job. Use of second language or euphemisms, like is very important, like for example, addressing the child at his or her level of comprehension. This does not suggest the use of baby talk, but rather employing words that have meaning for the child. This means not speaking to an 8-year-old as if he or she were 3 year and vice versa. Does a 3-year-old understand what it means to evacuate or vacuum the mouth, or rubber dam clamp? So we need to use these substitute, like dental terminology like air as wind, anesthetic as sleepy medicine, burr as a pencil or brush, caries as a brown spot, Explorer as tooth counter, matrix as fence for filling, X-ray as camera, radiograph as picture, handpiece as a whistling train. So we need to use all these euphemisms so to get the child within our control, so we can start our procedure. Now we have tell show do technique that will be deal in future slides, and we have desensitization. Desensitization, it was developed by James and later popularized by Wolf. It means to take away one's sensitivity to a type of behavior. So it is a therapeutic technique that pairs an anxiety evolving stimulus with response to inhibitory to anxiety, like relaxation as inhibitory of anxiety, visual imagery of anxiety provoking stimuli, with the patient maintaining profound muscle relaxation. So the technique calls for a hierarchy of fear stimuli, whereby the patient conquers fear or anxiety towards low anxiety or moderate anxiety stimuli before approaching the more dramatic stimuli. So the technique usually involves teaching the patient to induce a state of deep muscle relaxation, and while the patient is in relaxation state, tell him to imagine scenes that are relevant to his fears. So these imaginary scenes are presented to the patient in a graduated fashion, so that scenes provoking minimal anxiety are initially described and gradually more stressful situations are presented. So in this way we can manage the patient. So next one is modeling, that is also we are dealing in detail. Then behavior shaping, that is dental assistant or dentist teaching the child to behave. Contingency management, it is like we have positive reinforcement, negative reinforcement, timeout or punishment, or it is like a presentation of a positive reinforcer or withdrawal of a negative reinforcer. Okay, so positive reinforcer, like which increases the frequency of desired behavior, because we are giving a present or giving a toy, which increases the chance of patient to become very cooperative. Negative reinforcer, it is like withdrawal increases the frequency of behavior. We are keeping the parent out of the clinic. We are telling the patient that we are keeping the parent out of the clinic if you're not being cooperative. So it is the withdrawal increases the chance of the patient being cooperative. Okay, so these reinforcers can be material, it can be a social, it can be an activity, so it can be anything. So we can manage the patient by giving a positive or negative reinforcer. So what exactly is omission or timeout? So it is a withdrawal of the pleasant stimulus to reinforce good behavior. So asking the mother to stay out of the dental operatory makes the child cooperative. And punishment is like home, hand over mouth exercise, voice control, something like that. Distraction is a new method of behavior management in which the patient is distracted from the sound or the sight of dental treatment, thereby reducing the anxiety. By telling the stories of fairy tales, using slow instrumental music, or it is to relax the patient and reduce anxiety during treatment. We can switch on the TV and let the patient, the child watches his favorite cartoons. Can be an audio distraction, can be an audio visual distraction. So that is about distraction. After that we have parental absence or presence, and we have retraining. Retraining is a technique which is similar to behavior shaping, designed to fabricate positive values and to replace the negative behavior. So it is like avoidance, that is avoid extensive pulp therapy with pulp capping. De-emphasize and substitution, that is substitute high speed hand pieces with spoon excavator. And it can be a distraction, that is distract child with stories, activities and audiovisual aids, that is retraining. It is almost like behavior shaping. Then we have voice control, that is sudden and firm commands that are used to get the child's attention and stop the child from his current activity. So firm commands can be a very powerful tool for the patient management. Now we have physical approach, that is home, that is hand over mouth technique and protective stabilization. Hand over mouth technique will be dealing in detail, that is keeping a folded napkin over child's mouth gently and behavioral expectations calmly explained, used only with parental consent. Now let's see what is aversive conditioning. So aversive conditioning, it is an extension of overall behavior guidance designed to facilitate the goals of communication, cooperation, and delivery of quality oral health care. It includes many techniques, that is voice control, hand over mouth exercise, and physical restraint. All can be combinedly done. Now we have the tell, show, do technique. So tell, show, do is a cornerstone of behavior management, which was given by Adelson in 1959. So the classic model for communicating with child and favorably conditioning them to dental experience is, first we need to tell, then we need to show and do. So the verbal explanation of procedures in phrases appropriate to the developmental level of the child. In telling, explaining to the child exactly what you are going to do. After that, uh, the telling part is over. Then we need to show the thing which was explained earlier, that is demonstrating visual, auditory, olfactory or tactile aspects of the procedure, and the noise of the running hand piece, the material which will be used. So anything we should demonstrate it. So after that, without deviating from the explanation and demonstration, the dentist proceeds directly to perform the previewed operation. So that is first telling, then showing, after that doing. So there are many alternatives for this tell, show, do technique, that is ask, tell, and ask, tell, play, and do. All these are the modifications. Ask, tell, ask is explaining the procedures through demonstration in a non-threatening language appropriate to the cognitive level of the patient, and again inquiring if the patient understands about the treatment. So that is ask, tell, and ask. So that was about tell, show, do technique. Then we have home, that is already explained, hand over mouth exercise, introduced by Jordan in 1920, indicated in 3 to 6 year old child who exhibits defiance and hysterical behavior, and they can understand the simple verbal command, and they displays uncontrolled behavior, but it is contraindicated in less than 3 years and handicapped and physically and mentally challenged students, I mean the kids. Modeling and observational learning, it involves allowing a patient to observe one or more individuals who demonstrate a positive behavior in a particular situation. Therefore, the patient will frequently enact the model's behavior. So it can be done on siblings. The well-behaved sibling can be kept nearby, and he is very cooperative, so the patient also will try to model him. So it can be a poster, it can be film models or audiovisual aids. Now we are into the Electra and Oedipus complex. It is part of the psychology. It is seen during phallic stage. The key event in this stage, according to Sigmund Freud, is the attraction of the child to the parent of opposite sex, with envy and fear of the same sex parent. In boys, this situation is called Oedipus complex. Boys experience castration anxiety, which comes from fear of punishment. In this process of identifying with father, the boy not only takes up his behavioral pattern but also his ideas of right and wrong. In girls, this type of attraction is called Electra complex. Conscious sedation, a minimally depressed level of consciousness that retains the patient's ability to independently and continuously maintain an airway and respond appropriately to physical stimulation or verbal command, and that is produced by a pharmacological or non-pharmacological method or a combination of both. So we have many agents for achieving conscious sedation. It can be opioids, morphine, fentanyl, and benzodiazepines like diazepam, midazolam, lorazepam, barbiturates, chloral hydrate, propofol, ketamine, and nitrous oxide. Most commonly used is nitrous oxide for conscious sedation. So what exactly is diffusion hypoxia? So diffusion hypoxia is a decrease in PO2 usually observed as a patient is emerging from an inhalational nitrous oxide anesthesia. So the rapid outpouring of insoluble nitrous oxide can displace the alveolar oxygen. It displaces alveolar oxygen, which results in hypoxia. So all patients should receive supplemental oxygen at the end of the anesthetic procedure and during the immediate recovery period. So immediate recovery period, we should always make sure that we have sufficient supplemental oxygen for the patient, because nitrous oxide always try to this insoluble one which can replace the alveolar oxygen, so there will be hypoxia. So the nitrous oxide conscious sedation, there are many steps. First, we need to review the medical history and other medication of the patient, then see the vital signs, BP, pulse, respiration and saturation level, select proper size of the nasal hood, turn on oxygen and assess the patient with placement of the nasal hood over the nose, then patient's tidal volume to identify proper flow rate, then start the nitrous oxide at 10 to 20% concentration, then every 1 to 2 minutes it increases by 5%, and once the ideal signs and symptoms are observed, begin treatment. Upon completion of treatment, turn off nitrous oxide, then start administering 100% oxygen for at least 3 to 5 minutes to avoid diffusion hypoxia. Then we need to document the procedure, including flow rate, amount of time, amount of 100% delivered upon completion of procedure, and patient's response. So it is indicated in fearful or anxious child to accept dental treatment. Contraindication, mainly people, kids with cold, tonsillitis or nasal blockade, or preoperative children, and also for ladies with first trimester of pregnancy. So the signs are open or closed eyes, tears, trance-like expressions, speaking, laughing, abducted feet, open or closed hands. So that was about conscious sedation. That is again a question. Now we are into the theories of child psychology. We have basically two categories of theories. One is psychodynamic theories. Then we have theories of learning and development of behavior. So in psychodynamic theories, we have psychosocial theory, then cognitive theory, and psychosocial theory. So the famous psychosexual theory was given by Sigmund Freud, and cognitive theory by Jean Piaget, psychosocial theory by Erik Erikson, then classical conditioning by Ivan Pavlov, operant conditioning by Skinner, hierarchy of needs by Abraham Maslow, social learning theory by Albert. So psychic triad, it was given by Freud in 1923, that is tripartite structural model of ego, id and superego. So the behavior is influenced by the biological drives, that is id, then the social rules, that is superego, and meditating thought processes, that is ego. So it was a classical psychoanalytical theory of psychosexual theory. So he compared the human mind to an iceberg, that is small part above the water is conscious mind, and we have three components. It is the most primitive part of personality. It is the basic structure of personality which serves as a reservoir of instinct. Okay, whereas superego, that part of personality that is internalized representation of the values and morals of society as taught to the child by parents and others. It is essentially an individual conscience, and it judges whether the action is right or wrong. Whereas ego, it is a part of self that is concerned with overall functioning and organization of personality. through its capacity to test reality and utilization of ego defense mechanism. So ego is concerned with a state in which an adequate expression of it can occur within the constraints of reality and demands and restriction of superego. For example, hunger must wait until food is given. The ego spans all three topographical dimensions of conscious, preconscious, and unconscious state. So the ego is the executive organ of the psyche and control motility, perception, contact with reality, and through the mechanism of defense available to it, the delay and modulation of drive expression. So Freud believed that ego substitutes the reality principle for the pleasure principle. So that was the complex theory of psychoanalytical theory, or this theory where we have the three components: id, ego, and superego. So we already discussed this one, and now we have this psychosexual developmental stage, that is oral stage is up to 1.5 years. Anal stage we have 1.5 to 3 years, urethral 3 to 4, phallic 4 to 5 years, latency 5 to puberty, and genital puberty onwards. Okay, now we have the psychosocial theory, or theory of developmental tasks, given by Erikson. So he explains the stages of psychosocial development as like a ladder, where it starts from the bottom of ladder is stressed versus mistressed. At the apex it is integrity versus despair. So in infants it is like increasing complexity, that is stress versus mistrust, and in older adult it is like integrity versus despair. So each stage is characterized by different psychological crisis the person of that age group is undergoing, which is to be resolved before he moves into the next level. That is what this theory is all about, that is stages of psychosocial development. That is infancy, we have 0 to 1, where we have the problem of trust versus mistrust. This stage identifies with the development of separation anxiety with the child, dental treatment to be provided with a parent present, preferably holding the child. Whereas toddler 1 to 2 years, that is autonomy versus doubt. That is, child moves away from the mother but still retreats to her in case of threatening situation. So hence the parental presence is essential. Child gets pleasure by doing tasks by himself, so the dentist must give a feeling that the treatment is his choice. Whereas stage 3, that is early childhood, age 2 to 6 years, initiative versus guilt. That is preschoolers. This stage identifies with the development of separation anxiety with the child. Dental treatment to be provided with a parent present, preferably. So initiative versus guilt. For most children, first dental visit occurs in this stage. Going to the dentist is a new and challenging adventure. So exploratory visit is a good way to start the dental experience. Coping with the anxiety can develop a great sense of independence and accomplishment. Poorly managed visit contributes to guilt and failure. Whereas stage 4 is elementary and middle school, that is industry versus inferiority. Here the children are aimed at learning new skills and goals. The key behavior is to guide in setting intermediate goals and outline the child how to achieve these goals and positively reinforcing it. Children are not motivated by abstract concepts but rather status and acceptance in peer group, that is by emphasizing on how the teeth looks rather than occlusion, by comparing with peer groups, that is 6 to 12 years, where they are very conscious about their teeth. And in 12 to 18 years, there is stage 5 adolescent state, that is crisis between identity and role confusion. Parental authority is being rejected. Approval of peer group is more important for these age groups. So commonly orthodontic treatment is carried out in this stage because the peer group influence is high. So there may be loss of status for being one of the few in the group for not receiving the treatment, because they are very conscious, they are very much like being liked by the peer group, and they are very influenced by the peer suggestions rather than the parental one. So they seek orthodontic treatment or aesthetic treatments mostly by the peer influence. So it's important to make them realize that the treatment is done for them and not to them. Whereas 19 to 40 years, that is intimacy versus isolation. External appearance become important, therefore more focus on orthodontic and aesthetic treatment. In 40 to 65 years, that is creativity versus stagnation. And lastly, late adulthood, that is age 65 to death, that is integrity versus despair. So that is all about the theories of child psychology. We have many other theories I have not included, that is theory of cognitive development. They are not very important, given by Jean Piaget. Then we have other theories like hierarchy of needs and the theory of operant conditioning. So all are not very important, but mostly these two essays will be asked, that is psychosocial, this psychosocial developmental, and the psychoanalytical theory, and ego and super ego is also very important. So I'll come up with a fourth part of Pedoontic question paper discussion now. Next session. Thank you.